Pleasant good morning to everyone, wherever you are. I am Dr. Tariq Jagnarang. I would like to welcome you on behalf of PanCap to our webinar. I am your substitute host in place of Dr. Shanti Singh, who is unable to attend today's session. Nonetheless, I will bring the dynamism and continue with our session. Just before we get into this rich discussion that we're going to have today with Dr. Alan Landay, talking about understanding biological aging and non-communicable diseases in HIV, allow me just to give you a little bit of housekeeping so you can know what to expect and what to do. First and foremost, all your mics, they're muted. However, if you want to participate, participants can use the question feature on the webinar. Just look at your panel. There you can submit questions to the presenter or any other comments that you may have. We will share these questions to Dr. Landay at the end of his presentation, and he will try his best to respond to all of them. If he can't, we will try to send out answers afterwards. Just please note that also this webinar, it's been recorded for persons who are unable to attend, but they can actually listen to it and benefit from this session. And it will be uploaded on the PanCap website and other social media platforms of PanCap. And by attending this webinar, I want to you to understand you've acknowledged your consent for this webinar to be recorded. Also, the presentation that Dr. Landay is going to be sharing, it is going to be shared with you via your email. Let me don't hold you back from getting in between to Dr. Landay and his rich discussion. Let me start by telling you a little bit about who he is. And he has a lovely track record. There's so much to say about him, and so I don't know where to start, but let's start by saying that he is the vice president of the team science and a professor in the Department of Internal Medicine and Microbiology, as well as immunology at the University of Texas Medical Branch, Galveston. He also serves as the acting interim director of the Seeley Center of Aging. He has almost over 43 years of experience in HIV research. Dr. Landay was instrumental in developing the very first FDA licensed HIV antibody testing, and he has made key contributions to understanding not just immune activation, but inflammatory response and aging when it comes to the HIV population. For with more than 3 decades, Dr. Landay has been investigating many aspects of HIV in terms of clinical trials, working along with a specific group referred to as the AIDS Clinical Trials Group, where he led the Rush Immunology Support Lab and provided scientific leadership across the AIDS Clinical Trials Group network labs. He holds prominent positions and roles with this very group through several committees. He also has a working group focused on HIV and aging, working group related therapeutic vaccines, and microbiome research. His current research actually investigates neuroscience into HIV therapeutics, as well as applying aging principles to HIV care. Dr. Landay collaborates with several international bodies such as the UN AIDS as well as the World Health Organization on initiatives related to HIV and aging. And what's remarkable, he has over 600 published peer-reviewed papers, advanced knowledge on immune activation, inflammation, as well as microbiome in the context of HIV and aging. I can go on to tell you so much more about Dr. Landay, and it might end up I might end up presenting about him instead of you hearing this lovely presentation. So let me pause there, hand over to Dr. Landay. Dr. Landay, over to you, and all the best with the presentation.
Thank you, Tarek. Can you hear me? Well, Tarek, my voice is good?
Yes, excellent, loud and clear. Go ahead, Richard. You can switch slides. Just tell us next slide and we'll proceed.
Well, thank you again for inviting me to give this seminar to the group at PanCop and CARICOM. It's really an honor and a privilege to do this. As Tariq just mentioned, I've been in the HIV field since 1981, 43 years. And it's really gotten me to now thinking more about HIV and aging as all of our significant advancements in treatment and therapy through the years have led us to see our HIV patients now living longer. but also now they're developing the non-communicable diseases and comorbidities of aging. So that's what I'll be talking about today. In the overview, as you see on this first slide, I will be presenting epidemiology of the HIV pandemic, discussing the clinical implications for aging, which I think are very important to the audience today, because as clinicians or public health officials or researchers, you're all going to be interested in how do you deal with the aging HIV patients in each of your respective countries. I'll also highlight some of the basic biologic mechanisms associated with the idea of accelerated aging in persons with HIV. We really start to think about aging and HIV at age 50, whereas in our other aging populations around the world, we think about it as age 65, and that has significant implications on the clinical opportunities. And now at the end, I'm going to introduce emergence of novel anti-HIV approaches in the areas of geroscience called senolytics. So where are we today? We're nearly 40 million people living with HIV worldwide. And we know, again, the HIV epidemic has not stopped now, almost over 40 years later. We know that there are the people living globally. We know that 630,000 people have died of AIDS and 1.3 million newly infected. So we still have, again, new infections every year. And also we have people accessing heart. That's really a huge accomplishment for all of our people doing that. What we can see, though, if when we look in the Caribbean, where we're talking today with you, there are nearly 330,000 people living with HIV. And in 2022, we had 5.6 thousand who died of AIDS, and again, 16,000 newly infected, with 68% on ARV. So again, we can see the impact. What we're now dealing with is the life expectancy with and without ART. As you can see from this slide, a person without HIV is living on average 79 years in most of the world, or in the developed world, maybe a little less in some of the low to middle income countries. A person with HIV diagnosed at age 20, taking current medications, is living almost to the same degree at 71 years. So although people were saying they're developing comorbidities of aging, non-communicable diseases earlier, they are living almost a normal lifespan now, a little bit less, but almost there. But what contributes to that is if a person is diagnosed with HIV at age 20, the same age, but not taking their medications, then you can see only 32 years lifespan. So the ARVs that we have today, one pill once a day, and then moving to long acting, is having a huge effect on our abilities to see increasing lifespan. So really, there's a lot of background we need to consider in the aging of our HIV population in terms of what kinds of drugs have they been exposed to, and are they taking their medications and adherent to it, because that's going to affect their lifespan and outcome. What we can see is ART has rectangularized the survival curve. Can you click through the slide? Yes, there. So what you can see is that we now know that controlling the environment in HIV, that the survival after diagnosis is much more increased now in at 2002 than it was back at the beginning of the HIV diagnosis, where basically when I started studying HIV, many of the subjects that we saw in clinic were actually died within a month following their diagnosis. So really, we've had a huge impact, especially with the introduction of the protease inhibitors early on in 1995, and more recently with integrase inhibitors. And then just at the International AIDS Society meeting in Munich, we had the phenomenal news of the newer drugs giving every 6 months now for prevention and treatment. But what we're now seeing, though, is a greater number of persons with HIV age 50 and above, which is where we consider aging in HIV. That's the definition we've used in most of our studies, in low and middle income countries versus high income countries. You can see that in areas that you may be living in within the Caribbean areas, you're going to see much greater numbers of people there who are increasing with the 50 plus versus high income countries. Next slide. And also the number of persons living with HIV is increasing worldwide. If you look at the slides here, the highest is in Asian Pacific, that's the blue line, but right below that is Latin America and the Caribbean. And you can see again, in all parts of the world, our patients are aging. That's the wonderful news. But as you'll see in a moment, this comes with a cost. As people are aging now, they're developing more of these non-communicable diseases. And then click through this again, another. So what we're seeing is, and this is in the United States, is in 2022, only 2 years ago, over 50% of persons living with HIV are aged 50 in the United States. And again, they're living longer, healthier lives because of effective treatment, which I mentioned. But again, as you'll see in a moment, we are going to see more increasing complications. Now, this slide shows you very nicely what we can see over time. The number of deaths has dramatically decreased. But if you look at the orange part of these bars, other causes of death are increasing. And originally it was AIDS-related deaths were the majority, and the other causes 14% in 2010, 14 years ago. When we move on to 2022, only 2 years ago now, we have AIDS-related deaths much more reduced, but other causes of death at 32%. So these are the other comorbidities. So we have another kind of AIDS crisis that's approaching, the comorbidity crisis. And this is a uh, New York Times from 2009. So as you can see, that was almost, over 15 years ago. We were already recognizing this issue of comorbidities in this new crisis. And you can see the two people here, age 56 and 52. On the left, somebody with 25 years of HIV, suffered from memory loss, nerve damage, lipodystrophy, and fatigue. And on the right, short-term memory loss and 2 hip replacements. So now that's what you're seeing. But look, these are young men. They're in their 50s. So that's affecting these outcomes. What we're now seeing is that persons living with HIV are more likely to develop comorbidities. And although we're seeing this increased life expectancy, as you can see on the top, we're seeing less comorbidity-free years for people with living with HIV. So without HIV infection, comorbidity-free years, and with, we're seeing it's much lower. And so again, the comorbidities, the non-communicable diseases, are what are affecting our patients today and have the most clinical importance. This is data now that's from Lancet Infectious Diseases, looking at the number of persons who have comorbidities is expected to increase. If you could click through, please. And you'll see that here on the right, that those numbers of proportional individuals with comorbidities on the left are the HIV infected, and on the right, the uninfected. So you can see the numbers of comorbidities, 3 or more, in those who are greater than 65 is much larger than in those individuals who are HIV uninfected, who are also greater than 65. So again, it's not just having comorbidities, but the number of comorbidities are increasing. So these people are having multiple comorbidities. Next slide. And that's having a significant impact. The comorbidity is 1.5 to 2-fold higher in persons living with HIV, even when they're well controlled. So that's with a well-suppressed viral load below current cutoffs of 20 copies, and with good immune reconstitution that includes CD4 counts over 500 or even more into the normal range. What we're seeing now is cardiovascular disease risk, which is one of the major areas. We're also looking at non-AIDS defining cancers. We're looking at effects on bone and bone fractures, osteoporosis developing. Again, new scanning, new approaches for looking for bone health as you age, like DEXA scans and others. We also know liver disease, kidney disease, cognitive decline, and also metabolic disease. We're seeing much more diabetes and changes in the diabetes risk in our HIV population. Next slide. So here are the common NCDs associated with HIV and aging. Those include neurocognitive impairment. And in your next seminar, actually, will be on this topic, looking at neurocognitive outcomes in the HIV population. Dr. Bo Ansis will give a webinar in October on this important topic. And Dr. Ansis is a neurologist at Washington University in St. Louis in the United States, and we'll talk about the neurocognitive risks in our HIV population as they age, as well as what is the more increased risk for Alzheimer's or other neurologic conditions. We know about diabetes. That's also important. Please go back just 1 second. Thank you. We're also knowing, again, looking at diabetes and using drugs to treat, and I'll come back at the end, that metformin, a common drug used in treating diabetes across the world, also may have effects on aging, and it's a drug that I'll talk about in the class of cynotherapeutics. I'll introduce that concept a bit more later at the end of my talk, but just know some of the common drugs we're using to treat these comorbidities may also have effective on aging as well. We know there's an effect on the lung, chronic obstructive pulmonary disease. Cardiovascular disease is critical. It's a #1 killer across the world and affecting, again, at earlier ages, at age 50, our HIV population. Frailty. These are overall functional measurements. Our patients are becoming frail. Their mobility is reduced, their grip strength, their abilities to get around, and that affects your populations of HIV patients in your various communities because they can't get out of their homes. They're now becoming isolated. They're not being able to interact with others. So that really has effects from the mental health perspective. We also know about cancer. Kidney disease is critical. Bone, we talked about, and osteoporosis, liver, and then lipid disorders. And we are also seeing with aging, and also related to some of the drugs, weight gain is also a critical part. So we'll come back to some of that aspect later, how we might affect that. Next. So I'd like to now go and talk about 3 particular areas of cardiovascular disease, frailty, and osteoporosis. Next. What we're finding here is HIV and cardiovascular disease. The CVD risk is nearly 50% higher among people with HIV. CVD mortality, as I said, is one of the leading non-AIDS causes of death, as we see that occurring. And they occur even with low CVD risk scores in persons with HIV. So the risk scores that have been developed for the non-HIV population don't necessarily apply, because there's other underlying things like persistent inflammation and the effects, cumulative effects of drugs that the patients might have been on for the last 20 or 30 years. The earlier drug classes of the reverse transcriptase inhibitors, the non-nucleoside NNRTIs or NRTIs, actually given a cumulative risk may also contribute to some of these cardiovascular events. Next. But now we know that the Reprieve trial, just published 2 years ago in the New England Journal, shows that daily statin reduces the risk of cardiovascular disease in people living with HIV. This was the largest study ever done, randomized trial with a very strong clinical outcome in our HIV population. So it has tremendous impact in thinking about how we can prevent not just the cardiovascular risk, but also, which it was powered to look at, was the inflammation that occurs during HIV. And that's another added benefit of the statin therapies. And we'll talk about others that may also have on the aging side. So we also know HIV frailty and physical impairments are important. On the left part of the slide, you can see the age in years with HIV negative and positives. And for those greater than 65 on the far right, you can see that the frail and pre-frail individuals are much greater. On the right-hand side, you're looking at gait speed and grip strength in the HIV positive. So gait speed is reduced, as is grip strength. So these are all functional measures, the physical impairment. As I said, that's having a huge impact on the outcomes of our patients and their mobility to really get around, to be more interactive in society, because as you get older, you do lose your mobility in your natural aging. And again, what happens in HIV, you're accelerating this lack of mobility and you're getting more of an isolation to these HIV patients, so they can't get out and interact with society. We also know that HIV leads to osteoporosis, falls, and fractures. 18 to 40% of middle-aged experience a fall, and 13 to 25% with recurrent falls during the prior year. And you can see this in women. The fracture prevalence is higher in HIV in those at higher age levels. Again, 50 to 59, and also even going up further as people age. On the left, we're looking at the bone mineral density decline after ART initiation with continued decline over time. So we do know that a number of our drugs like tenofovir and others do have an effect on bone density and as well on renal function. So there's a double effect of the persistent inflammation leading to the NCDs, but also some of our current drugs also can contribute to some of these comorbidities in our patient populations. So it really leads us to thinking, how do we develop better drug classes, which we've done with some of the integrase inhibitors, and then our future drugs, which we're going to do in terms of long acting. So we now know that multiple comorbidities lead to multiple medications. So here, the NCDs and comorbidities can cross-react. These aren't independent. So when you get hypertension, you can also get neurocognitive disease, stroke, kidney disease, and dementias and others. So one comorbidity can lead to others. There's really a lot of interaction. Just next. And you can see here now, polypharmacy is the patient model. So you can see what happens is that the numbers of medications are increasing greatly in terms of what we're seeing, 400 patients modeled for 2030. So you can see across this, you're seeing now as you go up in across to the years of 2030, that we're going to see patients with more polypharmacy, more drugs dealing with cardiovascular, diabetes, osteoporosis. So as people are now aging more with HIV, there's going to be more needs of polypharmacy. How do these drugs for these underlying NCDs interact with their antiviral drugs? What happens when we start implementing long-acting therapy, giving a shot or a patch that lasts for 6 months? How will this impact now what happens in terms of monitoring outcomes clinically? We also know that there are basic mechanisms contributing to aging. These are the pillars of aging that you can see on the left that include epigenetics, inflammation, metabolism, and stress. All these are the pillars of aging that lead in a normal individual's aging to impact their aging outcomes into their 60s and 70s. But what happens is these aging mechanisms that we know about from healthy individuals now also lead to development of chronic diseases that you can see here that I've just talked about, like cardiovascular disease, osteoporosis, and neurodegeneration. Next. So what we're trying to do now is to understand this better. We really want to understand what's going on in our patients across the world. Well, within your part of the world, in the Caribbean, we have cohorts like the CASANET cohort. That's funded by the National Institute of Health, and it's actually under the IDEA program, the International Epidemiology Databases to Evaluate AIDS, IDEA. That's a National Institutes of Health program funded in the US that actually evaluates patients and cohorts of patients throughout the Caribbean and South America, Central America, and Mexico. So it's really throughout all of Latin America. But we have many other global cohorts elaborated here, including ALEA, which is an NIH-funded study I'm part of in Brazil, where we're studying 700 patients with aging. So one of the things I'd like to bring to the group today with the CARICOM and PANCOP group is, could we start to actually understand more across all of your countries by creating and looking at the clinical data in each country to see, do we see similar outcomes of comorbidities? What is the use of the antiviral therapies? What are your CD4 and viral loads? So we can begin to learn more, create clinical cohorts, and out of that, ultimately, we may be able to do more biologic studies and interventional studies as well. So in terms of the summary of our epidemiology and clinical data, due to art therapy, persons with HIV are living longer lives worldwide. So it's really been a tremendous impact on the global pandemic overall. We also know persons with living with HIV have reduced numbers of comorbidity-free years. So they have many more and multiple comorbidities and polypharmacy. So this is important clinically. Cardiovascular disease, neurocognitive decline, liver disease, kidney disease, frailty, osteoporosis, diabetes are among those most common in patients with HIV, living with HIV. And again, what we want to do in the future is leveraging clinical cohorts to study the aging HIV population. That's something we can do collaboratively with folks on the call today to really learn more about what's going on in your region, and it really will help us in the future how we devise new guidelines in clinical care. So now that I've set your stage from the clinical and epidemiology, I want to dive a little deeper into biologic mechanisms of aging and accelerated / accentuated aging in persons living with HIV. The idea is we're now learning a lot more from our colleagues in the aging world of how we can apply now to HIV. So aging can present differently regardless of previous medical history. And you can see the person, just click through it, please. And that one more. So again, two identically aged individuals, a person on the left, person on the right, both with the similar clinical history, but very different in terms of their vigor and resilience. So you can see that why is it that that person on the right is now running a race and the other one is homebound and in bed? That's what we want to understand, is what is the difference in terms of the basic biologic mechanism of aging from HIV that we can now learn about these outcomes. So just click through. One more. So what we're now seeing is evidence of accelerated aging in our persons living with HIV. In the upper left, we're looking at epigenetic age. So now what we're understanding is we can use these basic tools of biology, epigenetics, which are modifiable, to study biologic aging. And we're now understanding there's a difference between your chronologic age, what it says on your birth certificate when you were born and how old you are today, that's your chronologic age, and your biologic age. And we're now seeing, and I'll talk more about how do we measure that through epigenetics, and that's going to be an important tool in the future of how we study our HIV population. In the bottom left, we also see decline in telomere length in patients who are stabilized on ART. And then on the right, we know that there's multifactorial contributions of greater mitochondrial dysfunction. And many of this mitochondrial dysfunction might be due to the previous drugs, the D drugs, DDI, DDC, D4T. These are older drugs in the late 80s, early 90s that we treated patients with, who today, when they were 20 then, they're going to be in their 60s today, that might affect mitochondrial function. Next. So there are numerous studies that also demonstrate increases in inflammation that can drive accelerated aging, immune senescence, metabolic dysregulation, and loss of proteostasis. So these are all basic things that can contribute to this accelerated aging in HIV. Next. But aging is more than just biology. So note, I gave you biologic mechanisms, but what about structural inequities and lifestyle? That also contributes to aging in HIV. On the left are the structural inequities: gender, race, education, labor or economy, unstable housing, and food insecurity. All of these are going to contribute as well to the aging of our HIV population. And what about biobehavioral? Substance abuse. You have people with substance abuse disorders, perhaps. What about poor diet where you live? Low physical activity, stigma. People with HIV, lots of stigma. But there's also stigma in aging. There's discrimination, again, both from the HIV and aging. So these people now are isolated. It affects mental health outcomes. Loneliness. I talked to you about the idea about mobility. If people aren't able to get out of their house, interact with their friends, their relatives, their neighbors, or even get to their own doctor, that's going to create loneliness, mental health effects, and that's going to affect their aging outcomes. And then finally, low self-efficacy, their ability to get around. All of these factors affect this. So what are we doing to improve the health span is key to long-term independence. So this may be a new term. You have probably heard of the term lifespan, how long you live. You're going to live to 100, you're going to live to 80. That's your lifespan. But health span is different. And this is now getting into another new term called geroscience. Geroscience is the science of aging. And this is a whole new field of science and medicine. We actually are beginning to think about therapies, which I'll talk at the end of my talk, of new therapies of treating aging that we're applying not only from the aging field, but also to the HIV field. And the health span is now living a healthy life, living to 100, but not being in a nursing home, not having neurocognitive decline, not being bound to a wheelchair, but out actually doing things in your daily life, walking around the neighborhood, going on trips and whatever. But that's health span. That's living a healthy life to 100, not living to 100, but for the last 10 years being in a wheelchair or having mental decline. So we're now trying to look at how do we improve health span, and it's consideration of lifespan to consideration of health span. So think about this as a new term in your vernacular. We want people to have a good health span, not just a lifespan. And the domains used to characterize this, again, your neuromuscular function, cognitive, cardiovascular, metabolic, inflammation, body composition, and energetics. All of these are how we determine your health span and how that's going to have an impact on outcomes of your life. Again, there's a shift toward delaying this. Could you go back once, please? Thank you. So there's a shift towards delaying and compressing the period of lifespan when frailty and disability, which I just mentioned, increase, and therefore expanding and improving health span. So again, we don't want to have frailty and disability over the last 10 or 20 years of your life. You want to have that in the last, week of your life. I mean, that would be ideal. You're out skiing the afternoon at age 100, and you go home, and that's it. But that's the perfect life. You're doing skydiving, you're skiing, you're just as active as ever at age 100. And that's what we want to see and work with in our HIV populations, increasing their health span. Next slide. And we're doing this through understanding the hallmarks of aging. As I mentioned before, and then click through, click, thank you. Each of these hallmarks can be affected, and these are, again, basic biologic processes that occur. Some of them, and I'll talk about more, is dysbiosis. That is what happens to your microbiome. Those are the bacteria that live in the body, mostly in the gut. And as you age, you have a change in your microbiome that actually affects your health and outcome. And what happens is it goes from a healthy to a non-healthy microbiome. A non-healthy microbiome is dysbiosis. What affects that? HIV affects it. ARVs affect it, but also lifestyle and diet affect it. So it's not just the effects of HIV, but other ways in which you live and the way in which you affect that outcome. And as you can see, many of these others are affected, every one of them, every one of the pillars are affected by HIV and therapies. Next. So the one I'm going to talk about first of all is DNA methylation. This is the field of epigenetics. So what that means is that's a modification of DNA has been found to be informative as an epigenetic marker. So these are changes that occur, as you can see on the right, over aging, and that it can accelerate aging by the changes and determine biologic aging. So what we're now looking at is a chronologic clock versus a biologic clock, okay? And you can see in the orange versus the blue differences that look at things differently, so that your biologic clock may be very different than your chronologic. What you want to do is have at age 80, which is, let's say, your chronologic age, you'd love to have a biologic age of 60. So that's why people keep saying 60 is the new 50, or 80 is the new 60. So that's why we're starting to compare biologic versus chronologic age. And these DNA methylations, which we can measure in the lab, can tell us about biologic aging and biologic clocks. Next. So cellular senescence, that means the cells getting old, increases with age. It's a state of irreversible proliferative arrest driven by stressors on the cell. And you can see there the various stressors might include oxidative stress, wounds, and damage, oncogenic damage. So various things in your environment and in your living day can affect and cause senescence, but there's a natural aging process. So senescent cells demonstrate increased secretion of inflammatory signals. So this is what's going to happen, is there's a natural aging process that leads to the production of these senescent associated secretory phenotypes. And these pro-inflammatory SASP can now affect systemically. So that's a normal aging process that occurs. But HIV also has inflammation due to the fact that the virus is there and increases inflammation in the host. So we have two effects: HIV effect causing inflammation, natural aging causing inflammation, and these two come together then as you begin to age more into your 50s and 60s. So we have a double hit. Aging and HIV both lead to inflammation, and both now affect the non-communicable diseases like cardiovascular disease. Next. So what we want to now do is take this aging science, or geroscience, to target the pillars of aging. So I just mentioned with aging alone, you have senescence, you have inflammation, and you have damage. Now, what does that amount to? Well, that leads to various phenotypes like geriatric syndrome. So as you age, you see these geriatric syndromes in aging. That could mean sarcopenia, that means muscle weakness. That could be frailty, the ability or to be mobile, or cognitive impairment in your brain. So these are what we see in normal aging, but this is now accelerated. So when we ask about the geriatric syndromes in an HIV patient, we're going to see these at age 50, 55. But in a normal aging population, non-HIV infected, you're going to come up in the 65 to 70 range. So again, we're seeing an acceleration or accentuation of the geriatric syndromes. We're also going to see more of the chronic diseases of aging: dementia, cancer, atherosclerosis, diabetes, and so on. And decreased resilience. That's important. After you get an insult to your immune system or to the host, you don't bounce back as well. So when you fall, when you're older, you don't get up as quickly. If you're 70 and fall, or 20 and fall, very different in how you respond. Now, when you're HIV infected and aging, again, you're going to see reduced resilience. So your ability to get up from that fall at age 50 with HIV is going to be similar to somebody with 70 or 75. So that's important. You're also going to see more delayed wound healing, slower rehabilitation, and again, ICU care. If you go in for other diseases like cancers, you're going to get much more toxicity. Next slide. So what have we learned from aging research? Again, the basic biology of aging. Well, outward signs of aging, frailty, and other geriatric syndromes are prevalent in HIV 5 to 15 years earlier. Again, I've just said that, in well-matched uninfected donors. Again, you're 70 in an HIV negative, you're going to look like a 55-year-old with HIV. Slowing aging is more likely to expand health span than curing any single disease. So now we're looking at, okay, we could take care of their cardiovascular, diabetes, neurocognitive, but how do we take care of the basic underlying aging effects, the overall effect? We're looking at that. That's how we approach geroscience. Very exciting new opportunities. And again, there's no single biomarker of aging. Functional assessments, you need to do this together. So if you're saying, is there something I can take my patient, send them to the lab and say, oh, now they're going to age faster or not, or they're going to develop these diseases? The answer is no. it's really an integrated physiology. And again, we want to focus on these hallmarks and look at them overall and include them. So we look at functional measures like walk speed, chair stand, grip strength. We look at frailty, but we will combine that with these biologic epigenetic measures. So we're doing both laboratory and functional measures when you see the patients in the clinic or we study them in the community. And together we can now hopefully use these markers to predict outcomes. Next slide. So what factors underlie this? And you can see here, again, coming back to inflammation. What's driving that underlying inflammation and leading to the comorbidities? And again, many of these things are the toxicities that you had from the drugs, maybe persistent HIV because you're not compliant, other co-infections like CMV, or a leaky gut, microbial translocation. That's one of the features that we saw early on about 15 years ago, and actually contributes greatly to the ongoing inflammation that leads to comorbidities. Again, cardiovascular, bone, and so on. Next slide. So drivers and mechanisms of aging with HIV. I mentioned these. Inflammaging, that's a big one. That's the persistent inflammation from the causes I've just alluded to. But we have ART toxicity. The virus can still co-infections, not just CMV, but hepatitis, HBV, HCV, or other infections in your environment in the Caribbean. We know there are other retroviruses endemic in the Caribbean, like HTLV1. That can also, and we're studying that in a group in Jamaica, looking at HIV and HTLV1 co-infection in the Caribbean. We're also looking at chronologic age and socioeconomics and lifestyle. Next. So contributors to chronic inflammation. I've just mentioned, this just comes back to the same thing earlier, that it's chronic HIV, functional aging mechanisms, lifestyle. So it's not just the biology, but it's also your lifestyle, your diet, whether or not you drink a lot of alcohol, smoking. All of those are going to contribute to the outcomes of aging and chronic inflammation. So it's not just underlying biology, but also importantly, lifestyle factors. Next. So we do know, and I mentioned this earlier, there's evidence of accelerated aging by looking at DNA methylation. And on the right, we're looking at HIV positive in the red line, and in the black, the HIV health, or the negatives, or healthy individuals. So we're seeing now epigenetic age is older by 5 years in the HIV positive. So again, that means their biologic age is older with people with the same chronologic age. And on the left-hand side, you can see the same thing is HIV infection accelerates age according to the clock. These are the biologic clocks. And again, you can see blood data shows highly significant differences in terms of age acceleration to a level of 5 years of difference here. But it depends on the study, and it's an area we're now beginning to look at globally to see how we can use this as a new biomarker. Next. So epigenetic aging before starting and after being on heart. This is data that was just published from the Swiss HIV cohort study in the Lancet. And what it says here is epigenetic age acceleration over time for this particular marker. And you can see that it goes up over time before therapy on the left. So epigenetic aging accelerates before therapy and then decelerates after viral suppression in people with HIV. Now, it doesn't normalize, though, back to where you should be. So as you have untreated HIV, you're having an acceleration of these epigenetic changes, increase in biologic aging. That's going to lead to more of the comorbidities we just talked about. You treat the patients, you decelerate it, but you don't bring it back to what would be a normal, healthy donor. And you can see on the right, there's a lot of variability. Next slide. We're also looking at this not only in the blood, but in tissue. So this is a study we published just recently in one of our journals. On the left, you're looking at chronologic age, so the person's without and with HIV, exactly the same chronologic age, But on the right, you're seeing there's now an increase in their biologic age in the blood, but also in the gut. So your aging occurs not only in the blood, but throughout the body at all the organs. And we now know that there's a difference in the blood aging and the aging in the tissue like the gut. And we can now begin to quantitate this. Next slide. And we also know it's associated with pro-inflammatory markers in persons living with HIV. So when we see accelerated aging with the biologic clocks, we also see it associated with these inflammatory markers. Next slide. So what we have is aging is a highly complex process. Improving health span is key to improving the quality of life. That's the key. We want quality of life. Persons with HIV show increased aging across tissues and cells. And finally, HIV induces inflammation and reduction of telomere length, which affects biology. Next, we're going into the last part, which is novel medications. How do we treat this? How do we intervene? Next. Well, we're now looking at senescence as a final common pathway. So as we're driving senescence, we think at the bottom, this is leading to inflammation and ultimately to age-related diseases like cardiovascular, neurocognitive. So now, how do we now attack senescence to reduce the aging effect in HIV? Next. And these are all the different approaches. I won't go into them. You'll have the slides to look at in detail, and I'm happy to answer questions. But what we're using are senolytics. These are anti-aging drugs that kill the cells making these inflammatory mediators. So we have senolytics and senomorphics. Senolytics selectively kill senescent cells. Senomorphics suppress the senescence phenotype, which means the inflammatory mediators. Look on the right. These are drugs, the senomorphics, that you might be familiar with. The JAK inhibitors are used commercially. Ruxolitinib, baricitinib are actually used in cancer. Rapamycin is used as well in transplant, and metformin in diabetes. So these are drugs that are being repurposed from other fields now to be looked at in the HIV arena for anti-aging effects. Next. So we mentioned the AIDS clinical trial group that I work on. We're now looking at this and we're developing cellular senescence biomarkers, and we're actually looking at new interventions with senolytics and using these two, dasatinib, which is a cancer drug, with quercetin, which is a flavonoid. So we're now actually taking drugs that are being used in the aging field, applying them to HIV. Next. The first in human trial was one that looked at this in idiopathic pulmonary fibrosis, and it did show an effect on the SAS protein. There was another one in diabetic kidney disease. So this was the first in human trials with these senolytic drugs, not related to HIV, but did have an effect. Next. We're now taking a geroscience approach to look at accelerated aging with HIV and how we might affect that, as you can see on the far right. We're now taking aging with geroscience interventions. Next. And what we're looking at is there are future directions for senotherapeutics, potentially can target a number of different areas. And again, I won't go through the different areas, but we're really beginning to look at these as a potential new opportunity for us as a whole new range of treating the aging phenotype of HIV in a new field of science called senotherapeutics. It's now in an experimental phase in the US, but hopefully these kind of drugs and approaches can have worldwide applications, especially with common drugs like metformin and others that might have an effect. Next. So what we've learned is, again, addressing the mechanism of aging is key to reducing multimorbidity. Potential therapeutics hold promise, but we have a long way to go before they're going to be prescribed to your patients. But it's an exciting new world. In the interim, the major issues for changing care is to focus on prevention of comorbidities common with aging. Again, treat hypertension, stop smoking, cancer screening, cardiovascular disease mitigation, frailty screening. So all of this is how we can have our current effects from both the clinical and public health. So where are we today? People age differently. Aging involves multiple biologic and non-biologic factors. Many of these may be affected with HIV. And again, we need to evolve our thinking and find ways to promote healthy aging in persons and an increased health span in our HIV population. Next. So this is my team at Rush, Matt Mendoza and Lynette Harris at our Office of Team Science. This is our building, Old Red. We're the oldest medical school in the UT system, and this was built in the late 1800s. I'd like to thank you all for your attention and happy to answer any questions. Thank you.
Thank you so much, Dr. Landay. This was an excellent presentation. I can't reiterate what one of the persons said in the comment. The comment was, "This is real serious stuff," and definitely it is. Your presentation was very enlightening. It gives us a lot of perspective to think of as HIV clinicians, reapproaching many things that we do when we're dealing with our patients. There are a number of questions. Allow me to share them, and so you can respond. Guys, if you have any questions, just a gentle reminder, just type within the question section, put it there, and we're going to have Dr. Landay respond to these. So the first question, does art in any way contributes to these NCDs?
Good question. The answer is yes. We do know that there are effects of things like tenofovir on bone, kidney. So there are toxicities, and we know there are lipid from previous lipoatrophy, lipodystrophy. We know that weight gain due to integrase inhibitors. So the answer is yes. There's also the effects of older drug. Abacavir was a drug associated potentially with cardiovascular outcomes. So, I mean, we're now evolving our drugs. So we're trying to move away from these drugs and the toxicities of driving NCDs to less toxic drugs, but we know there may be residual effects. So depending on how long somebody received that drug, we may see residual effects as people are aging overall. So we have to take that into account.
Definitely, we do. There's another question that is asking for your comments based on HIV inflammation as it relates to insulin resistance and diabetes.
Mm-hmm. Absolutely. There's a great deal of interest in inflammation driving that and insulin resistance and diabetes. That's absolutely an underlying effect, driving diabetes in general, and how we treat it with other drugs may also have an effect on the inflammation. So as I mentioned, metformin, an interesting anti-diabetic drug, may also be a anti-aging drug, and that's being looked at for other clinical data in a large study in the US that's looking at neurocognitive outcomes and cancer outcomes and cardiovascular outcomes. So I think there's a lot of intersection here, and clearly inflammation is an underlying effect on many of our NCDs. So how do we now target that inflammation is critical for now preventing some of these NCDs of aging, and some of the drugs I just mentioned may also have an effect there.
Thank you so much for that response. And the third question that is coming out, does the study that you mentioned find who is at higher risk of NCDs with persons living with HIV, for example, male, female, ethnicity, minority groups, or etc.?
Great question. I think we know that as people age, there may be women are more at risk for certain diseases than men. I think you also have to ask, are people smoking? What about their lifestyle? That's also smoking, substance use, alcohol use, diet. All of those are going to contribute to the NCD risks. But we also know that there's an effect of, I didn't mention, reproductive aging. That's another aging effect I didn't mention. Very important. What happens in the pre, peri, and most post-menopausal effects in women? And we know actually that there's an increase, and we're now studying this in postmenopausal women, an increase in HIV replication in women when in the postmenopausal phase. And many women, you don't get estrogen replacement therapy. So there's now an additional effect on women of reproductive aging due to loss of estrogen in their postmenopausal phase that may drive more inflammation in women and make them, again, more susceptible to a number of these non-communicable diseases. So that's another equation. Chronologic aging, biologic aging, and now we're going to have to add a third one in my next talk on reproductive aging.
Definitely, definitely. We welcome those talks. They definitely are timely, helps us to prospectively think. They are, let's see, um, not any more questions, but comments. Aging is definitely a topic that is receiving a lot of attention globally. And so we love that comment. There is another question. Currently, older women outnumber men. Feminization of the older population. Is the trend also seen in older persons living with HIV?
Yes, that is. Women, we're also seeing that as well, that women will live longer, and that's also in overall, that women are a larger proportion of our aging HIV population as well. So we're seeing that as well. In terms of aging and a global effect, we're actually now working with the World Health Organization and the HIV group to look at adding, right now, when you look at the WHO guidelines, aging is not mentioned. There's no mention of aging. So we're now working with the HIV group at WHO and the aging group, because in the aging guidelines, we're looking at healthy aging 2030, they don't mention HIV. There's no even thought about what is HIV in the aging. So I'm now working with the World Health Organization to try to get incorporation of these guidelines. Also now working with PAHO in your region as well to develop more around HIV and aging. So we hope all of that will come to bear, both from the clinical and the public health aspect, and use a lot of the basic work that I've talked about today to really try to intervene to increase health span and in our populations who are aging with HIV.
Thank you for that response. Another question, how soon would senolytic therapy become a norm as part of treatment for
Yeah.
persons with HIV?
Great question. I'd love to say tomorrow, but we're far off. Just we're literally in the US just starting these trials. But what we can do, and this is the part we could work with folks on the call, look at some of the drugs they may be on. What about if you're on metformin? Is that affecting you more? What about if you're on a statin? Is that affecting you? We now have data to suggest that both metformin and a statin can affect epigenetics and maybe biologic age. So we may be able to take, again, with large groups like yours here today, look at some of the clinical data on these standard therapies people are on already and see how that's affecting their aging phenotype and outcomes.
Oh, excellent. And I think you just answered the next question, because someone was asking, how has metformin shown to have a positive effect on retarded aging? And so um, I can move on to the next. How does multidimensional and episodic disability contribute to HIV and aging?
Yeah, again, it's all there. I mean, we have to look at the big picture, and we have to ask we have to look at lifestyle, we have to look at biology, we have to look at the drugs. Are you taking the drugs? How well, what's your mobility? And yeah, all of this together, it is what we're saying, person-centered care. We have to look at the whole person and integrate all of our effects to that person and what we're doing to treat the HIV, people living with HIV. And the International AIDS Society in Geneva, and I'm working with them on this whole person-centered care concept. It's all about the person and where they are and what they're doing, and not just treating their cardiovascular or their HIV or their diabetes, but it's the whole person. And it's also a lot about, I said, mental health and all of what they're doing. And are they isolated? Are they, all of that. That's important to the care of our population.
Thank you for that response. And there are no more questions. There are just two comments. Persons thanking you for sharing, thanking you for the topic, especially showing the link to chronic disease, and which is very prevalent, not only around the world but highly prevalent in the Caribbean. And it was been very beneficial to us. Given that it's just around our time at 12 to close off, I want to first and foremost let me thank you, the participants. We just have around 133 of you who were involved in the session. I'm pretty sure you did benefit a lot from what Dr. Landay presented. We now can take this back to our clinics and share with our peers. I also want to take the opportunity to thank you, Dr. Landay, for this lovely, updated, well guided, evidence based presentation. And I want to invite you, the participants on this call, to join him on the 10th of October in collaboration with PanCap again. There's another webinar. Look out in your emails. You're going to see it. He's going to be talking about HIV associated neurocognitive disorders.
That's no, let me correct you. It's not me. It's Dr. Ansis I mentioned from WashU. So
Sorry about that, Dr. Answers, but yet again, it is a beneficial topic for us to take a look
absolutely.
at. And so please do join us. And thank you to our support team at the end there at PanCap and PanCap for hosting these sessions. They've definitely been of tremendous help.
So
We will
Tariq,
share the. Go ahead.
I'm sorry. I just want to make a point to your audience. I mean, there's lots of data. I know I was probably fast and it may have gone quickly. They'll have the talk recorded. They'll have the slides. Please, you can provide my email contact to your participants. If they have individual questions, please ask them to send me an email. I'm happy to answer. I'm happy to engage and talk more about opportunities on the research, on the clinical or public health aspects of what I covered today. Thank you.
Thank you so much for that offer, Dr. Landy. And so thank you guys for coming out. Have a good day. Enjoy your lunch. All the best.
Thank
Goodbye.
you so much. Thank you again. Bye-bye.